Hello, good afternoon, everyone. I'm Dr. Yogesh, and it's my privilege to welcome you all on behalf of AstraZeneca and Hemas Pharmaceuticals. I welcome you all to the second session of our training program, empowering primary heart care physicians and healthcare providers in heart failure care. So we had a very good first session, which was done by Dr. VK Chopra last week, and for second session we have Dr. Sanjay Mittal. Dr. Sanjay Mittal needs no formal introduction. One of the most renowned cardiologists across globe and leading heart failure specialist in India, an excellent orator, an excellent teacher. Dr. Sanjay Mittal is Senior Director of Clinical and Preventive Cardiology, Heart Institute, Medanta Medicity Program. He is Head of Heart Failure Program and EECP Lab and Research Projects in Medanta Medicity. He was one of the very first few founding members of the concept of heart failure clinics in India. He has an experience of over 30 years and has been involved in extensive training and working at various hospitals in Colombia, New York, New England Medical Center, echocardiography lab in Cleveland, Buffalo, New Hampshire, etc. He has more than 50 publications in various national and international journals and has also authored several chapters in textbooks. He has been investigator for various clinical trials and has delivered over 200, I'm sure that number must have gone high by now, lectures in various national and international conferences. He's also actively involved in organization of various conferences, both at national and regional levels, which really help a lot in dissemination of modern science. And his field of interest are echocardiography, heart failure, clinical cardiology, and research. So without much ado, I would hand over the stage to Dr. Sanjay Mittal, who is going to enlighten us on the topic role of lifestyle modification in management of heart failure. Over to you, sir.
Thank you, Yogesh. First of all, let me wish you a very warm afternoon for my friends from Sri Lanka. The topic which was introduced last time, about a week back by Dr. VK Chopra was an important topic. And I am going to dwell on further to what he had already discussed, because this is a big menace. All of us practicing physicians and cardiologists come across this problem day in and day out. I'm going to focus mainly on the lifestyle modifications, and I'm also going to cover a little bit about the concomitant medications which we are using for heart failure treatments, and also what the role of us physicians and nurses is going to be in handling a situation of heart failure. But first, let me recollect what Dr. Chopra mentioned last Wednesday, maybe, that heart failure is a big problem. And as we are advancing in age and our technology in surviving the acute insult or the heart muscle, we are surviving the people, but the subcom that is that the person lands up in heart failure sooner or later. And this is a long-term problem, as Dr. Chopra discussed the last time. It has a huge mortality and morbidity, which was discussed. Unfortunately, any kind of heart disease, whether it is the commonest of them all, a coronary artery disease, if I look at the data from our country and the world, the predominant cause of heart failure is coronary artery disease, which leads to damage to the myocardium and reduction in ejection fraction and ensues the heart failure population. And the other causes are dilated cardiomyopathy, hypertrophic cardiomyopathy, restrictive cardiomyopathy, any kind of cardiac disease which we know of, valvular, pericardial, congenital arrhythmias, ultimately would lead to myocardial injury, damage, and progression of heart failure. The other thing which has to be remembered now with all of us presenting here, what we see today is the tip of the iceberg, which means that people, when they come with breathlessness, suffocation, not able to walk or do their course of life, it's the tip of the iceberg. But predominantly today, what we do is staging of heart failure, which means there are a lot of people amongst us, almost 22% of the population globally, who do not have any signs and symptoms of heart failure, or for that matter, any damage to the heart function at all. And they do have risk factors which would in eventuality lead them to development of heart failure. This includes hypertension, coronary artery disease, diabetes, and family history of cardiomyopathy, etc. If you look at this, what we call as stage A heart failure, which means right now the heart function is perfectly normal, echocardiogram would be normal, but these guys have risk factors for subsequent development of heart failure in life. And these people, if we address right now at this level, can be prevented from going into ventricular damage and heart failure. Stage B is sometimes which we can in clinics detect that the person has some kind of myocardial injury or damage, maybe a previous myocardial infarction or cardiomyopathy, whatever. They have heart function which is less than normal, but yet no symptoms whatsoever. They can do all their activities. And these patients also, almost 1/3 of the population is roaming around with this kind of a population, and they do not realize what they can lead to. If they don't attend that thing, right, then they're going to be a problem and have precipitation of heart failure. 12%, only 12% of the population is that which actually has damage to the myocardium, heart function is low or hypertrophy or whatever. And these people actually land up with symptoms to us, and we can detect and treat them. And unfortunately, many of them, almost 30% of them, would actually land up in stage heart disease. That means do whatever you may, the person remains symptomatic, breathlessness again and again, their activity is limited, and a problem is there. Dr. Chopra also mentioned about the diagnosis. So echocardiogram is a very important thing, and pro-BNP and BNP is something which is used very commonly to differentiate the cause of breathlessness to be of heart failure origin, or the breathlessness of being anemia or respiratory origin. And this can be used in lab, but most importantly, echocardiogram, which has to be used. Why echocardiogram? It just not classifies heart failure into those who have reduced ejection fraction. That means when we calculate left ventricular ejection fraction, if it is less than 40, that means this person has substantial damage to the myocardium and is ranked in heart failure with reduced ejection fraction. On the other hand, there could be people who have preserved ejection fraction. That means ejection fraction calculated is above 50, but still continues to have breathlessness and exertion and all the signs, symptoms of heart failure. And this is what we initially cause as diastolic heart failure. Preserved ejection fraction, but diastolic heart failure. The third category and fourth category are those who have a mid-range between 40 and 50. Most of these people actually behave more likely to reduce ejection fraction group, and nowadays the criteria are merging together and the limits are actually merging together. So these people could be of two kinds. One, those who had initially low heart function, ejection fraction was less than 40, but now has improved ejection fraction. Or those who had ejection fraction was normal and now are slowly deteriorating. So those are the two kinds of things which we have to remember in this thing. Most importantly, people of reduced ejection fraction have definitely treatment. People with preserved ejection fraction have limited amount of definitive treatment available. And there are certain new drugs which are coming into the market. So let's discuss about when we try to manage these patients, where and how we should go ahead. Point number one, we cannot completely treat any of the person who has heart failure. We can control them, but we cannot completely treat them. So the treatment usually is lifelong. That is point number one. Point number two is, what are we targeting? If we can't treat or cure a particular disease, what are our aims and objectives of treatment? So the thing is, the first thing is, the person is coming to us with symptoms. So let us elevate symptoms, reduce symptoms, make the person comfortable in day-to-day life and his activities. The second thing is his quality of life, obviously, which is dependent on his symptoms, should also improve. And this should lead to certain hard endpoints, which means we should prevent the person having repeated hospitalization for heart failure. we should try to improve the ejection fraction if the ejection fraction was low. And ultimately, the best thing would be to add years to life. That means the person should survive more, the mortality should be reduced. So these are the primary aims of what should we be doing for treatment of heart failure. The other part is, what are the ways we can do that? I am going to be elaborating the first and the foremost, which is the lifestyle measures, which is the very common thing we doctors, physicians, and cardiologists are having no time for addressing to. And this is the most important component and should be done as early as possible. I'm going to dwell on these things. This includes exercise rehabilitation program, dietary interventions, and also we have to handhold the patients and educate them and the family members for a proper care. These are the things that I'm going to discuss today in length. The second important thing is, what are the drugs available which are known to change the outcomes, as I said on the left side of the screen, which you can see. The third thing, which is important, is if the person does not have these controls by lifestyle measures or pharmaceutical treatments and has certain classical examples of diseases which can be contributed and treated, like bypass surgery or ICD or CRT, not what I'm going to discuss today. Probably in the last session of this continuum, we are going to discuss, but the first 2 points I'm going to discuss today. The first thing is lifestyle therapies, which can be effective through the various stages of heart failure. And one important thing which we have to address here is the earlier and more stringent lifestyle changes we adhere to, the better outcomes we can result in. And it is very clear in the literature, and I'm quoting the articles in the bottom line here. We talk about medical management, but the medical management, if it is associated with comprehensive nutritional and behavioral changes, it has been seen that it synergistically impacts heart failure pathophysiology as well as symptomatology. And also, there is enough data to suggest if we adhere to a comprehensive nutritional and behavioral changes, this leads to improvement in quality as well as outcomes as far as the quantity of life is concerned and the effectiveness of the medical care. The 2 points on the right are very important points which we have to understand. The important is the 2 things, medical management and lifestyle changes, actually work together to cause the maximum improvement in both kinds of heart failure, whether we talk about people with reduced ejection fraction heart failure or those who have preserved ejection fraction and still have heart failure. So lifestyle measures are important for all of them. And the second important thing is there is a stronger evidence that heart failure can be prevented. As I mentioned about stage A and B heart failure, lifestyle changes, if we inculcate at the level of stage A or B heart failure, we can prevent heart failure occurrence and thus by the complication of the heart failure also. So this is something which is very important. Let's talk about what are the ingredients of the lifestyle, good lifestyle. One is I'm going to talk about general cardiovascular health guidances, which means people who are potential to get cardiovascular disease and the cardiovascular disease potential to get heart failure. If we can prevent cardiovascular disease, we can also prevent heart failure. So that is why we have to emphasize few things. I'm going to talk about those few things. One, in the nutrition and diet, more vegetables and fruits, more whole grain food items, healthy sources of proteins. We are talking about proteins which are important ingredients, but we have to realize fish, seafoods, and in the vegetarian dishes, legumes, nuts, and low-fat diet, dairy products are important. Chicken also is an important thing. If we have to take lean meat is important. We have to restrict ourselves to liquid plant oils, which is like soya bean and canola oil. Those plant-based oils which freeze at room temperature have wrong types of fats and should be avoided. And this is something which is in general basic principle for guidance of dietary control for heart disease. We should avoid what we like. That means beverages which have added sugars, Coca-Colas, Pepsis, and all those aerated drinks have to be avoided. Processed foods, we are cooked and recooked in heat, are to be avoided. Processed meats have to be avoided. High food with salt items have to be avoided. Those things all lead to all three things. It leads to overweight, obesity. It leads to high incidence of diabetes, hypercholesterolemia, hypertension, and we know all these four ingredients are big risk factors for development of heart failure. So I have 10 points which I'm going to discuss now as far as the lifestyle measures are going to be concerned. The first is try to maintain a healthy body weight. And by healthy body weight, how do we do that? We have to realize one important thing, and that is what we have to communicate to all our patients. Nutrition or diet is like fuel to the engine, and it should be in proportion to what our body's burning capacity is. So in a simple way, we have to maintain a healthy body weight, because throughout the life, if the body increases, we think that it is a sign of health, but actually it is a sign of disease. And increase in body weight should be avoided. And this is something which is the first message I want to give. Over the last 3 decades, 30 years or so, increased energy intake and sedentary lifestyle. So what we are doing is, at one point in time, we are reducing our activities, and at other point in time, we are increasing our calorie intake, which leads to the shift of balance towards weight gain and all those absolutely wrong problems. A healthy dietary pattern coupled with at least 150 minutes of moderate level physical exercise. Moderate level physical exercise is one where your heart rate increases to 70, you become a little bit breathless, but you are able to speak out complete sentences. And this is the level of exercise we should be able to do about 150 minutes every day. And the last but not the least, we have to find excuses to be active through the day. So those are important things which we have to do. Also, one point we need to realize that as we advance in our age, our metabolism comes down. So if I'm 20 years of age and I'm 40 years of age, every decade of life reduces our burnout capacity by almost 100 calories per day. And that is why our requirement for nutrition also goes down. If we become inactive with age, also that is furthermore of a risk factor. The second important point, as I said, fruits and vegetables. These are important things, because fruits and vegetables, and I'm able to say here, there are a couple of vegetables and fruits which have to be best avoided. Potatoes, which we like most, is the one to be avoided the most also. Why? Because it contains too much of carbohydrates and starch, which lead to high calorie problems. The other thing which is important is, a basic principle is, we should advise to take more of colored fruits and vegetables, which means I take dark green vegetables, because they contain a lot of irons and vitamins, and this has to be inculcated. Leafy greens, peaches, have more nutrients than the less colored or light colored vegetables. So basic principle is, advise take dark colored vegetables and fruits more than the light colored vegetables and fruits. The third point is, whole fruits and vegetables are better than the juices. Most of the people that come to us and say, can I take banana juice or citrus juice and all? I always advise them take the whole fruit, because it gives fiber, which is good for your health in the long run, and that should be inculcated. Frozen fruits are better because they preserve the nutrient value more as compared to the fresh ones itself. And last but not the least is, avoid fruits and vegetables which actually are in the market with added salt and sugars, because this is free calories and free hypertension which we are buying on the basis of our food intake. The third point is, that foods which are mostly with whole grains, as I said, should be taken rather than refined grain, the polished grains. Because when we polish the grains, we take out all the vitamins under the skin of the grains and also the fiber which is available. And these are a loss of nutrients, which means we are taking more calories and less vitamins and nutrients. That's why it has to be more in the whole grain rather than the polished grains. So this is something which we have to be knowing. Why? Because it is associated with reduction in CVD, stroke, cardiovascular disease, strokes, and metabolic syndrome across the globe. And that is why it is promoted to take whole grains rather than the polished grains. The fourth point is proteins. I did mention about taking proteins. If we are vegetarians and we have to take plant-based proteins, we have to actually look at sources like soybean, lentils, beans, chickpeas, and split peas, because they are good source of protein as well as fiber. Also, legumes and nuts are very important sources of omega-3 fatty acids and certain other factors which are lower the cardiovascular risk, and this is very well known. If we are non-vegetarian, seafood as well as fish, this is something which gives us very good nutrition and the proteins. Almost 2 to 3 servings of fish per week is something which is important and has been known to reduce the stroke and cardiovascular disease. Also, if we look at the dairy products, low-fat dairy products, skim milk and skim milk products like curd, which is from the skim milk, and cheese, which is also from the skim milk, can be used as a good source of proteins. Lean meat is important to be addressed. Red meat should be best avoided, specifically if it is processed red meat, because it contains a lot of bad cholesterol and high calorie, which can cause a problem. The fifth thing is, as I said, liquid plant oils. Those plant-based oils which actually freeze at the room temperature should be best avoided because they contain higher amount of saturated fats. The liquid plant-based oils have more polyunsaturated fats and monounsaturated fats, and that is why these are good. And the substitution of these fats into the diet actually helps in reducing cardiovascular disease. The sixth factor is that we have to choose minimally processed foods. The more we process the foods, the more we damage the vitamins and the nutrients inside the food items, and we are ending up taking empty calories. Ultra-processed foods are very bad, and this is something which is an important message we have to give to our patients. The seventh important thing, which message I want to give as far as lifestyle is concerned, is that we have to minimize intake of beverages and food with added sugars, because added sugar is just pure carbohydrates and pure calories. The moment we take sugars and sugar-based drinks, it is absorbed in totality, increases the insulin levels, increases the chances of weight gain and hypercholesterolemia. Every extra calorie we take is converted into fat and stored somewhere or the other in the body. There is no store of sugar in the body. Every sugar part is converted into fat and only stored. So added sugar adds to the beverage actually are free calories, and unfortunately empty calories are very good sources of diabetes, obesity, as well as high cholesterol levels, and should be best avoided. A word about alcohol. Well, there is a huge bit of confusion about alcohol, but simple formula is, if you have not been drinking, don't start drinking. It's not a nectar. It is alcohol, which is going to have some other side effects if we take in a large amount. But if you are drinking, controlled drinks are okay. And what we say is, for ladies, a lesser amount of alcohol is permissible, maybe about 1 drink a day, maybe 30 ml of equivalent of alcohol, hard liquor. And if you are a man, up to 2 drinks per day should be the upper limit, not beyond that. The more you take it, the worse is the outcome. And these are the guidelines from 20 to 25 dietary guidelines which I have quoted here. The other important thing is the confusion about alcohol is it has a J-shaped curve. J-shape means just the like a letter J. If we take higher, the risk goes up. If we take in adequate amount, the risk is minimum. But if we take a minimum amount, the risk does not increase in proportion to higher alcohol. So it's a J-shaped curve rather than a U-shaped curve. The ninth is very important, and this is important because I'm not only discussing about the hypertension now, the heart failure is also important component of salt. The more amount of salt we take in our diet, it would extract more fluid because the body regulates the concentration of the blood, and this leads to decreased excretion of fluid from the body and high volume, which leads to increased blood pressure. And also, if a person has heart failure, volume overloading and heart failure precipitation is going to be more likely. A person coming to us with heart failure, we have to let them know, control their salt intake. That would help them control blood pressure as well as recurrence of heart failure. So the salt content is more focused on sodium content, not the sodium chloride alone, sodium content, because sodium content is important determinant for the blood pressure control. Also, there has been observational studies which suggest that reduction in sodium intake blunts out the age-related hypertension and also reduces the cardiovascular risk. And as I said, that it is very important ingredient to control heart failure as well. And DASH diet is important continuance of low sodium diet, which has been improved. And what is DASH? Is an acronym for dietary approaches to stop hypertension. And I strongly recommend that we all should recommend this diet for people who have existing heart failure. This is a schematic of DASH diet, but more importantly, the right side of the picture is almost the things which we have recently discussed in the first 9 points. The left side of the picture is what I want to focus on. A person who has grossly uncontrolled hypertension, we try to limit the sodium content of their diet, daily diet, to less than 2,000. A very difficult thing to less than 2,000, but how do you practically manage this? I have a simple formula which I advise to my patient. Which salt you take? So if you take 1 kilogram of sodium chloride, which is coming to your household for cooking purposes, we actually see how many household members are there, if there are 3 or 4, whatever the number is there, plus how long that the salt packet lasts. If it lasts for maybe 30 days, that means the average consumption of salt per head per day is about 10 grams per day. So you can simply divide 1,000 by 30 and by the number of heads. So it gives per house per day per day consumption per head. It should be less than 5 grams of sodium chloride, or if we talk in absolute terms of sodium, it should be less than 2 grams. So that is what the recommendation levels for hypertension and heart failure is. Last thing about the diet is about the fluids. I don't restrict fluids in my patients. I have more focus on restriction of salt content. However, if the person remains to have heart failure, and specifically if the person is in associated renal dysfunction, because as we know correctly, nearly 25 to 30% of people with heart failure would also have associated kidney disease. These people should be restricted to fluid restriction and depends upon their heart failure status. So a recommended correction for more than 6 to 8 millimoles per liter per 24 hours is advised for hyponatremic patients. If the person has low sodium, we have to restrict free water intake to less than 6 to 8 millimoles per liter of sodium. And this is something which is important. I would restrict my fluid intake only if I am not able to correct my heart failure with just my other dietary controls and the person remains symptomatic. A word about exercise recommendations. Exercise is very important. Whether you have heart failure or you don't have heart failure, or you have whatever level of your heart disease or no heart disease, the more you exercise, the better your outcomes are going to be. I'm telling about the healthy people. If you are looking at your healthy personal situation, it has been very clearly seen personal physical inactivity is a very bad predictor of the future heart failure and cardiovascular events. So if you are maintaining your physical activity level and you are being active through the day, it is very important precursor to reduce the incidence of heart failure. This has been proven. The second thing is the improvement. If our level of physical activity is X, but by training, regular training, we can improve our cardiorespiratory fitness. This lowers down the heart failure risk over a period of time and also reduces our body mass index. This is something which is very important. So be active. This is very important message. And the simple mantra of what our recommendation for activity is, two important messages. Point number one, try excuses to be active through the day. So it is not one-time activity I'm talking about, it is the daytime activity we should be worrying about. If we talk about the weekly activity schedule, it should be around 30 minutes every day for 5 days, at least a week, or amount of activity per week should be around 150 minutes of moderate intensity activity per week, or about 75 minutes of strenuous activity or vigorous activity a week. That is something which has been recommended. And also, we have to realize these are things besides the overall status of being active through the day. Find excuses to get up, walk a little bit. These are things. Why? Because it has been seen the more we are active, it reduces inflammation, it reduces autonomic imbalances, it reduces vascular endothelial dysfunction, it improves hemodynamics by reducing the blood pressure and arterial relaxation, it decreases chances of atherosclerosis, and is also improvement in clotting and thrombotic situation, which has been shown. So this is something which has been proven. That is why we have to promote exercise to all our people with heart failure. Be cautious. They should not be pushing themselves too much when they become too much symptomatic and land up with heart failure hospitalization. But a controlled exercise is very important. The last component of my communication today, and then I'll take questions, is pharmacological management. I'm just going to give you the glimpse of how and what we should do. We already know what kind of management strategies we have. There are so many possibilities for heart failure with reduced ejection fraction today. We have ACE inhibitors, ARBs, and ARNIs working comparatively together in the same pathway. So we have to give only one component of them. We can combine these things together, either ACE or ARBs or ARNIs, whichever is available in the country. The second component is the beta blockers. Again, class 1 indication is the person remains tachycardic despite beta blockers. We talk about ivabradine for them. If the person is iron deficient, we have to check iron deficiency, give ferric carboxymaltose, as Dr. Chopra described in the previous thing. We have MRAs as the third pillar, mineralocorticoids receptor antagonists in the form of spironolactone, eplerenone. These are the two things which have known to reduce the mortality. All these four pillars we talk about, the ACE, ARBs or ARNIs, and one pillar, beta blockers, the second pillar, MRAs, the third pillar, and the fourth pillar, recent development is SGLT, the repurposed diabetic drug, SGLT2 inhibitors. They have shown to reduce the mortality in people with reduced ejection fraction heart failure and should be given in the first instance on all our possibilities. The few things which I want to mention about the heart failure medications is the first, that any person with heart failure with reduced ejection fraction should receive one of these, either ACE, if the cost effectiveness is to be looked at. Nowadays, the ARNI's cost is also low, so we can rechange it. But what the recommendations say is heart failure with reduced ejection fraction with chronic symptomatic heart failure with reduced with NYHA 2 to 3 symptoms, we have to put them on ARNIs. If they were on ACE inhibitors, convert them to ARNIs, but make sure at least 36 hours duration is there as a gap between the last dose of ACE inhibitor and the first dose of ARNIs. Otherwise, the chances of is there, and we have to avoid that. So we have to choose one of them, but ARNIs have been standalone better drug than even ACE inhibitors, should be preferred. Even in hospitalized patient with heart failure, before discharge, we should give, because it has been seen if we don't start before discharge, it is something which they would never start. And this is why in a checklist of patients who have been discharged or are being discharged, these 4 pillars have to be there. The second thing is that ARBs and ARNIs are recommended as first-line treatment in heart failure with reduced ejection fraction, as I've already mentioned. But the second line of treatment is beta blockers. Beta blockers, once contraindicated, are the drugs which have the maximum amount of mortality benefit in people with heart failure with reduced ejection fraction. Along with that, it reduces sudden cardiac deaths. It improves the ejection fraction to maximum. Just besides the ARNIs, beta blockers improve the ejection fraction maximum, but it takes about 6 months for the effects to come. We have to be cautious. Once we start beta blockers, we have to be cautious. The person may gain fluid, so weight charting and blood pressure charting is important predicament which we have to tell our patients, and we have to monitor them very carefully. They have benefits in patients with coronary artery disease, diabetes, old or young people, women and male, across the races. So everybody has to be given beta blockers until unless the person has significant bradycardia, which is a contraindication for giving beta blockers. They all should be given beta blockers. The third pillar is mineralocorticoid receptor antagonist. Again, as I said, it is a drug which we have to be cautiously not giving in a person with a very poor kidney function, because they can worsen the kidney function. If the calculated eGFR is less than 30, we don't give it. If the eGFR is above 30 ml per minute per 1.73 meters square, and the second important thing is potassium is lower than 5. If potassium is above 1.5, we have to hold the MRAs, because they can cause dangerous hyperkalemia and arrhythmias and certain cardiac death risks. So this is something which we have to be watching for. And also a person, if the person is on MRAs, we have to watch for the renal function and the potassium levels at time to time interval. Eplerenone, due to its higher sensitivity to aldosterone, may be a preferred drug. Some people have gynecomastia after taking spironolactone. So eplerenone is a better drug, although a little costlier, but can be given people. And as I said, SGLT2 inhibitors today are the golden drugs, because whatever the ejection fraction level, reduced ejection fraction, mid-range ejection fraction, as I described, and preserved ejection fraction, they have been shown to benefit the outcomes as far as hospitalization and death is concerned. A word about urine pills, diuretics, loop diuretics. Loop diuretics are very important components. Rather, for symptomatic improvement, you have to give a person diuretics so that their fluid and salt comes out of the body and their breathlessness improves. But the problem with diuretics is the diuretics have to be curtailed down to the euvolemic level. If we continue to give higher diuretics, they become a contracted volume. The kidney injury is more, the hypotension is more, because of which we may not be able to give the first 4 pillars of the medication. So diuretics are essential, but the realization is we have to just target them, tailor them for the symptomatic purposes. This is something which is an important message we have to give. If a person is not tolerating or not having enough amount of urine, loop diuretics can be given injectables, and sometimes metolazone or chlorothalidide, they can actually help in increasing the effectivity of loop diuretics. But the fact is, if the person has attained euvolemic status, we have to then down escalate the drugs. In certain population, even vasodilators, the isosorbide mononitrate and hydralazine combination has been proven to be beneficial. And the recommendation is in American African population alone. In the rest of the population, it's not been proven to be of benefits, unfortunately. There is not enough data in the South Indian population, but we have certain indications when person cannot be given the mineralocorticoid receptor antagonist because of renal dysfunction and whatever, we can consider about it. Digoxin is the last option. We can still give digoxin if a person remains tachycardic and has hospitalization, and we cannot give any more dose of the 4 pillars. There are certain new things above the annual which we can discuss about, but I think it's more of the theoretical indication. If a person has repeated hospitalization despite the optimal medical management, vericiguat, a newer molecule, can be tried to reduce the chances of recurrent hospitalization and death. But this is only a class 2B indication as of now, not class 1 indication. I have already talked about the funny channel inhibitor, which is ivabradine. If a person remains having heart rate of above 70 in sinus rhythm and has symptoms of heart failure, despite beta blockers, we can consider ivabradine to be given those patients. A word about the monitoring and management of heart failure medications. What we have to do is, as I mentioned about the situation of ACE inhibitors, ARNIs, we have to talk about the side effects of cough, angioedema. If the person has SOS, stop ACE inhibitors or ARBs, because this person has a life risk of giving problems like this and should be red marked not to be given in the future. Again, similar kind of ARNIs risk is there. They also have low blood pressure, lowering blood pressure chances, and we have to be watching them. In the follow-up, if a person is receiving these drugs, we have to ask the person to report back to us with the blood pressure and pulse rate charts so that we can optimize the doses on a frequent clinical visits. For digoxin, again, hypokalemia is a very deadly combination along with deteriorating renal function, because if the renal function is low, the digoxin level can dangerously go so high that they can cause digoxin toxicity. For beta blockers, as I said, pulse rate, and we have to be cautious. They have not led to hypotension and fluid retention. If they have fluid retention, increase the diuretic a little bit rather than reducing the beta blockers. If we are talking about diuretics, again, electrolyte imbalance, hyponatremia, as well as hypokalemia has to be watched for. Worsening kidney function we have to watch for. And I very clearly advise my patient to take weight in the morning hours. And if the weight is dropping down, we can actually hold the diuretics or reduce the diuretics. If it is increasing, we can escalate the diuretics depending upon what it is. Mineralocorticoid receptor antagonists I've already talked about. We have to talk about renal dysfunction, time to time management. Every 2 or 3 weeks, I do my creatinine clearance assessment in people who are on these drugs, specifically in reduced ejection fraction. Again, when we talk about vasodilators, we have to educate our persons to watch for blood pressure and specifically the postural hypotension types. A few things about the contraindication of heart failure medications. Hypersensitivity for ACE inhibitor is very important, and same way the ARBs, hypersensitivity is important. And ARNIs, also previous angioedema with ARBs and ACE inhibitors, we have to be very cautious in starting ARNIs also, because they also contain ARBs and they also contain sacubitril, which can precipitate angioneurotic edema like this. So the last thing for the nurses and the practitioners here, I give a message, and the message is very clear, that we have been advising the treatments to them, which the doctors in the clinics would do. But the proper dose adjustments and proper judgment of the side effects is very important, which has to be done on a regular basis. Along with that, a proper education to the patients is most important. And not only the patients, but the family members. So this is a time-consuming activity, and we have to understand that we have to educate the patients and the family about the disease, the magnitude of the problem, the risks involved, so that the corrective actions and regulations can be done, and the risks problems down the line can be mitigated. So they have to be educated about self-care, lifestyle modification, as we discussed about, and symptoms and risk monitoring, as we discussed about what can be happening. You watch their blood pressure, it can go down, they can get dehydrated or congested, weight monitoring, and the pulse rate monitoring has to be educated to them at home. And here, the role of nurses is of paramount importance. So nurses should understand that the patient as well as family members have to be properly educated about their health disease status and the fact that they are now going to be taking care of them at home. And this is their responsibility to manage themselves at home. They have to communicate constantly to the nurses, which are the pillars of communication between the doctors and the patients. It has also important component of assessing the psychological. People are there who are very depressed, anxiety levels are high. They have to address to them. There are people who are psychiatric patients, so they have to be assessed by them according to their capacity to understand the treatment sites, and which is very important for the outcomes for the condition. So there are three components what we have to counsel. First, make sure whenever we counsel a patient, the counseling should be in a proper environment. Don't be pushy. Don't try to push them that, okay, you have to understand fast. I just have 5 minutes, 10 minutes. You have to understand, the patient should understand it first. If the patient is not understanding, the message is unclear and inadequate. So it should be an unrushed environment, and the information given should be acknowledgeable. The person should understand and acknowledge that he has understood. It should be safe, respectful. We have to be very clear that we have to maintain the decorum, and the person should be respectfully addressed to and should be pleasant. It is also known that the communication be completely honest, no hiding of the facts, because the more person understands the seriousness of the situation, the more the adherence is going to be, and between the family members as well as the patient. The third important thing is there has to be a consistency of counseling. That means if a doctor, a cardiologist is communicating, or a general practitioner is communicating, or a nurse is communicating, the communication should be on the same platform. So we have to have a comprehensive assessment, have an action plan of communication to the patient, and that is something to be executed. And as I said, in my clinic also, and everywhere in heart failure clinics, we have to cover these 9 points in our communication to the patient as well as family. The first thing is explain that the heart failure symptoms occur and they can occur again. And they should know a little bit of pathophysiology to let the patients know that this is why they occur and this is how they can counter them. They also should know what are the causes of heart failure, diabetes, hypertension, cardiomyopathy, and all those things. How to recognize symptoms, breathlessness, decrease in activity status, climbing stairs, and all those things. What to do if the symptoms occur? We have to let these people know. I have to let the person know every day in the morning, after toilet, before breakfast. They have to weigh themselves, maintain a weight chart, bring that chart to us or communicate to us through emails or WhatsApp if we have that channel available, so that proper monitoring is there. A rationale of treatments, just writing a prescription is not important. They should know why those medications are being written, and that is why the compliance is better. Specifically, SGLT2 inhibitors, genital urinary infection is common. So they have to be educated. This is an important medication, and you have to take care of your private parts so that the infections don't happen. Importance of adhering to the pharmacological management, because it's a lifelong treatment. They have to continue the treatment. The moment they stop it, 40 to 50% of them would have a recurrence of the heart failure. Refrain from smoking. It has to go for good. They have to be told about the prognosis, the advanced directives if they were given by the consultant physician. Drug counseling has to be done, and all these 16 parameters have to be educated to them, including the side effects, potential side effects of the drugs, what drugs should be given, not be given with them. NSAIDs, the painkillers are the biggest bane. They should be educated not to take painkillers instupidly because they can cause fluid retention and worsening heart failure. Signs of intoxication and all those things have to be made sure to the patient. Last but not the least, the patient is not alone. The whole family has to be educated. It's not just what to do and what to do, what not to do. After hospitalization, the first visit should be within a week, because this is the vulnerable time. They may be adhering to the medications or not. And this time, if they are not adherent, they can go into bad disease of problems. So the most important thing is realizing the first visit is the 1 week time so that the upscaling of medication can be done. Thereafter, the person may not have to come physically, but telephonically, depending upon the person's availability and the situation, we can do it every week for 2 to 4 weeks, every 4 weeks for 3 to 6 months. That is what we usually do. And every 6 months thereafter, the person has to be actually evaluated. There are certain laboratory things, as I mentioned, depending upon the MRAs, mineralocorticoid receptor antagonists, the diuretics, the acid ARBs, and other things. Kidney function has to be done within 3 months. If the person is on warfarin, they have to be educated accordingly. And these are important messages we have to be given. So, ladies and gentlemen, I'll end my talk here with the key take-home messages that heart failure is a chronic condition. There is no treatment for a complete cure for this, but there is a control of it, a treatment for it. And this has to be addressed to the patients very carefully. The treatment and the condition depends upon the causative factor, the heart's ability to pump effectively, and this is leading to fatigue, shortness of breath, and fluid retention. Adverse lifestyle and comorbidities must be managed effectively to treat heart failure. Thus, nurses play a very vital role to educating the patients and the family what is the disease situation and how to actually take care of the lifestyles. A heart-healthy diet, low in sodium, saturated fats, and cholesterol, along with the regular physical activity, is crucial for managing heart failure. Mind it, heart failure does not mean to restrict all activities. They have to be inculcated activities. Pharmacological treatment for heart failure typically includes medications like ACE inhibitors, beta blockers, diuretics, aldosterone antagonists, which aim to improve heart failure, heart function, and reduce fluid buildup and manage their symptoms. And last but not the least, patient and family counseling, regular monitoring of symptoms, and involving the family members are essential components of proper heart failure management to reduce hospitalization and to reduce mortality. I finished my talk here and I'm ready to answer questions if there are any.
Thank you, Dr. Sanjay, sir, for a wonderful presentation as usual. It was wonderful and very easy to understand. We have one question in the chat box. So before I open it for the audience, I'll read out. For audience, please put your questions in the chat box if there are any. So there's one question from Dr. Sunit Karunaratne. The question is, isn't heart failure with mid-range ejection fraction resembles more HFrEF than HFpEF with regards to treatment effects?
Yeah, wonderful. Thanks for asking this question, Dr. Karunaratne. So, as I mentioned, heart failure with mildly reduced ejection fraction, to my understanding, resembles more in heart failure with reduced ejection fraction portfolio. Because as I mentioned, it is either heart failure with preserved ejection fraction, dropping their ejection fraction down to mid-range, and on the path to making it to reduce ejection fraction, or it was already a reduced ejection fraction, which has now come to mid-range ejection fraction, which now use a terminology improved ejection fraction. It's still 40 to 50, but it's not normal still. So in my opinion, all the drugs which were indicated for reduced ejection fraction has been found to be effective in mid-range ejection fraction. The only problem is the data is scanty. That is why the indication is class 2A as of now, not 1. But I'm quite sure as the data grows, they are going to become class 1 indication for mid-range ejection fraction. So I treat mid-range also as reduced ejection fraction. The second point which I wanted to mention here, when I have a normal ejection fraction of 55 to 65 for males and 60 to 70% for females, anything lower than 50 is a reduced ejection fraction. So the only reason why mid-range is being given scale is because of unclarity and lack of data. Otherwise, for all practical purposes, in my clinical sense, mid-range is reduced ejection fraction and should be treated in accordance to that.
Thank you, sir. There are no further questions in the chat box. Any questions from the faculty? Okay, so in the absence of any further questions, sir, I think your presentation was so clear and elucidative that it itself answered most of the questions. So I'd like to conclude the session. Firstly, I'd like to thank Dr. Sanjay Mittal for taking time out of his very busy schedule and agreeing to be speaker here. He's one person, go-to person who always has been with us, and having learned a lot from him, I think he's like the encyclopedia when it comes to cardiology. So thank you, sir, for your very insightful session. And I'm sure this will help and go a long way in improving the management of heart failure patients in Sri Lanka. Thank you to Sri Lanka College of Cardiology again, Dr. Chandrike, Dr. Nawamali, who gave us this opportunity to begin this very noble concept of establishing heart failure clinics. And finally, thank you to all the delegates, all the nurses, doctors, and cardiologists joined the program. And I think without you, this program would not have been successful. So thank you all. Looking forward for similar participation in the third session as well. Thank you, Dr. Sanjay sir, once again, on behalf of Hemmas Pharmaceuticals and AstraZeneca and Sri Lanka College of Cardiology for this beautiful program. Thank you.
Thank you.